Have you heard of comfort kits, particularly used in hospice care? I'm going to be talking about those today, what they mean, and what I have done in the past to ensure that at end of life, patients remain comfortable. Let's talk about this some more. Thanks so much again for showing up. I'm Abigail, and I am here to ensure we all die better at end of life by normalizing these conversations and education about death and dying. So let's get into it today. We're talking about comfort kits. If you haven't heard one of my other videos about where I mentioned comfort kits just briefly, comfort kits in hospice care are usually, you may hear this term, and they are usually a set of medications that are grouped together, and they're either put in a box or a Ziploc bag, depending on what pharmacy with whom you work or from where it comes. And they have a bunch of medications in them that are usually used for symptoms that pop up at end of life when that patient is declining. Examples of comfort kit medications usually include things like morphine, things like lorazepam Ativan or Haldol, things like Tylenol for mild pain or for, temperatures. You can get very high temperatures at end of life. And things like suppositories for bowel constipation, because constipation is a frequent symptom at end of life. That's kind of a standard comfort kit that I've seen, just in my line of work, particularly in hospice, and just kind of basic types of medications that you run into. Really good type of stuff. Now, what I did in my years, just when you have many years of experience, which I think it was kind of a lot of experience, 15 years of experience, you just learn so much, and you always want to be changing to update your best practices, because hopefully you're constantly learning, especially from any mistakes or any kind of close calls, or even anything that even wasn't maybe a mistake, but maybe could have been done better, and you're implementing different interventions to ensure that you're doing things better. And of course, really educating your staff and the unit of care for that patient. What I want to share in this very short video is just general things that I did to the comfort kits to ensure comfort. And I worked, a couple of these I added in, and then another couple of them I worked with one of my previous managers, who was wonderful. And we worked on this and got this implemented, and it worked really well. So generally, when someone is admitted to hospice, they usually, you review all the medications, you update the medication list, and at the time you order a comfort kit. That is a way to be prepared, because we know that at end of life, there are certain symptoms that will for sure pop up. And we also, just so you know, it can be called a comfort kit or an E-kit. So for emergency. So we know that at end of life, there are certain symptoms that always pop up, and we need to be prepared for that. So having these E-kits / comfort kits in the home or the facility can ensure that medications are on hand already. So if something pops up out of the blue, we know, we can go ahead and start to administer some, Ativan quickly, some morphine quickly, or maybe the patient, is constipated and hasn't had a bowel movement in a day or 2 or 3, depending what their normal basal status is with bowel movements, and then start to, at least give a medication to start the palliation process, and then we can really evaluate the care plan and order something a little bit more routinely. That is ideal. So what I want to emphasize with these comfort kits is this is a quick little Band-Aid. This does not mean you have the comfort kit and everything is done. What we need to ensure is, if you look at my video series that is titled What Happens to Every Person That Is Dying, particularly in part 1 of that series, I talk about how we properly prepare for medication administration once the patient is no longer able to take routine medications. How do you ensure therapeutic levels are maintained? How do you ensure palliation and avoid interruption in those therapeutic levels? So please refer to that video. Really want to emphasize that comfort kits, E-kits, they are just a quick little Band-Aid. If you are ever dipping into that comfort kit and you have to give that medication, whether it's Roxanol, short-acting morphine, Tylenol for a temperature, Dulcolax suppository for bowel movement, you need to make sure that, okay, we've given that PRN or that as-needed medication. What are we going to do after this? Now the patient's comfortable maybe for the next hour, maybe few. Maybe they had a bowel movement. Great. What are we going to do after this to ensure that the patient remains comfortable? I will be getting into bowel movement stuff in particular. And then, like I said in my other video series about what happens to every person that is dying, that goes into more medication specific stuff in terms of pills. But we need to make sure that even though we give something from the comfort kit and the patient is comfortable, we need to think a little 10 steps ahead at least, or at least a few steps ahead. What are we going to do in place? What are we going to start giving routinely to ensure that patient remains comfortable or the patient continues to have a bowel movement, blah, blah, blah. Okay. So that's kind of my disclaimer with comfort kits. But my whole job here is to share what I have done, what I implemented to help ensure that these patients remain comfortable. So depending on the patient's diagnoses, depending on certain medication concerns, depending on potential allergies, things like that, or drug reactions, or if a patient was located in a different area outside of the private home or skilled nursing facility or hospital, certain locations where the patient may be residing can actually require different forms of medication being used. So let me just start with the basics. We have, obviously patients that are at risk for seizures we need to make sure that there are certain medications on hand if and when the patient should develop a seizure, say like a grand mal seizure, for example. Ideally, in that case, you have orders in place to transition to something routinely. But sometimes I know we can't take care, that can't happen for everybody. So in the past, what I did is I had an additional seizure comfort kit. In that seizure comfort kit was very simple. We had the routine comfort kit or E-kit that was given to that patient, ordered and given to that patient. Please know that all this was done with physician orders, of course. And also we would get an order for the seizure comfort kit. And in that seizure comfort kit, we had just 3 Valium suppositories that could be given, every 15 minutes, if the patient was in a seizure state. So obviously, and then you'd call the physician. I think in those orders, what I also included is, administer Valium suppository every however many minutes, until seizure ceases, and call physician for additional orders. Because if you have a patient that's in a seizure, you obviously want to give them medication. You've got it on hand. You can give the Valium suppository. Great. Check number 1 is done. But check number 2, which is the really big one, is make sure that you get the orders that you need to continue keeping that patient comfortable. So that's why I always included call physician for additional orders. Okay, so that was our seizure comfort kit. The other comfort kit that we had, and we use this a lot also with our palliative patients, was the cardiac comfort kit. And in that cardiac comfort kit, obviously we'd give them the routine, basic E-kit, they would have that. But in the cardiac comfort kit, we'd also order, in that cardiac comfort kit, we had IM Lasix, intramuscular Lasix. So obviously, we had intramuscular as a form of giving that medication because it acts more quickly than the oral. And also, if someone was unconscious and couldn't actually swallow any pills safely, they were guaranteed the medication if it was given intramuscularly. So oftentimes, again, we would look at the diagnoses. If the patient had a history of cardiac disease, particularly if they were at risk or if they were already on something like Lasix or spironolactone, whatever it is, and they were definitely at risk for fluid buildup, flash pulmonary edema, fluid overload, whatever that may be, that would really work well for them. Other types of comfort kits that I put together, which were good, were in the cases where I had a Dilaudid comfort kit. Now, I had this because sometimes patients were either particularly sensitive to morphine or toxic with morphine. Morphine just really was not a good fit for them. Morphine in general is a very good medication. And again, it's not just given right at end of life. It's often used for people who have cardiac issues to dilate the blood vessels, drop the diaphragm, help them breathe a little bit more easily. So it's not just at end of life, but obviously for this case in these kits, it is mostly, but it can be used for other things. But sometimes patients there's a very small group of patients that maybe don't tolerate morphine well. So in those cases, maybe they have been on a fentanyl patch for a while. You really want to try to do a kind of a similar medication to similar medication transition, or kind of use the same thing, depending on, again, individualized case scenarios. So in that case, long story short, I put together with my team a Dilaudid comfort kit. So where they, might have had the regular comfort kit, but we would not order the morphine in that comfort kit, and we would get a Dilaudid comfort kit, which would just be the orders for Dilaudid for, mild, moderate, severe pain, shortness of breath, whatever it may be, and the doses for that. And that worked out really well, particularly for these patients that couldn't tolerate morphine. Sorry, now I think a truck is driving by. Hi. Other last comfort kit I want to cover, and this was because, we have, in hospice and palliative care, you have patients that are not just in their private home. They could be in a skilled facility. They could be in a hospital for usually a very short stay, or they could be in these assisted livings or RCFEs, residential care facilities for the elderly. Assisted livings and RCFEs, even though they can look vastly different. One can look like a big facility, the other one can look like a small home. Even though they can look pretty different, they are under the same rules, regulations. And what's really interesting about these is if there is not a nurse on site, particularly an RN, they can't give anything rectally. And these cases in RCFEs, most of the time they only have med techs, and even in the assisted livings, they may have a med tech. And these med techs can't give anything rectally. So what you need to do is you really need to think about, well, what can they give? They can give pills, and sometimes they can't even crush them or they can't even give liquids. So in that case, you can't even use Roxanol to administer by the facility med tech because they're not allowed to give Roxanol. Now, I know that over time rules and things change. So of course, always refer to the most current policies and procedures and rules and regulations. In this case, we would have a standard comfort kit, and we would keep the Roxanol and everything like that because our nurses can go in and administer. But in the cases where we're at a facility and the patient still may need a medication, like they might need an as-needed morphine, we would have an MSIR, which is morphine sulfate immediate release. These are little pills that can usually dissolve pretty well, even in the mouth, to administer by the med tech so that they're still within their scope of practice, but you can still get that patient some as needed morphine in the mouth while, the nurse is on the way, while the nurse is working on other orders from hospice. So those were our main comfort kits that I added in addition to our other regular standing comfort kits that we already had in place. And they were, again, the seizure comfort kit, the cardiac comfort kit, the Dilaudid comfort kit, and the MSIR comfort kit. And again, the MSIR was strictly based on the location of the patient because the med techs or caregivers at the facility were restricted in terms of what they could provide and what they could give as medications. So let me know if you have questions, if you had other really cool ideas with comfort kits or use anything else and you think that could be helpful to our group here, include them in the comments. And again, we'll always either respond directly to the comments in the comment section or do a video to ensure that we cover it, particularly if I find it helpful. And I always like the feedback because I swear to goodness, nurses, particularly in the field, they are so darn smart and have so much to offer, particularly because they're at the bedside and they see so much and learn so much. So love you guys. Let's continue to make sure all of us, die better at end of life and continue to normalize these conversations and education about death and dying. I will see you soon. And again,